Hello, welcome everybody. Welcome to the joint GLI-GDI workshop on access to diagnostic treatment and care to end TB. Before we get started, I'd like to go over a few items so you know how to participate in today's event. So your microphone has been muted to avoid background noise. We encourage you to turn your webcam on throughout the session whenever you can. Would like also for you to please change your display name if you haven't had the chance to do it. So just so we can see your name and your country if possible. Here's a couple slides to show you how to do it if you don't know. You just click on participant on the bottom menu bar, you hover the mouse over your name, you click on more and you click on rename and you can enter your name and country on the screen name. You will have the opportunity to submit text question and comment to today's presenters by typing your questions into the chat. You can send questions via the chat at any time during the sessions. The moderators will collect them and they will address them after the speaker's presentation in the allocated Q&A sections. You will also have the opportunity in session by submitting a request to do so via the chat or by raising your hand. The moderators will record your request and inform you when you can intervene. They will have also the opportunity to provide feedback in the end of the session evaluation survey, which will appear directly in your browser once the meeting closes. And it's important you complete the survey right after the workshop, as the link will only be available for a short period of time. You will receive a certificate also for this workshop based on your attendance and the completion of the evaluation survey. Finally, please note that the session is being recorded and the recording will be available to the public a few days after the session. It is now my pleasure to introduce you to today's chairs, Dr. Elisa Tagliani and Dr. Sarabjit Singh Chadha. Thank you.
Thank you very much, Caroline. Good afternoon, good morning, and good evening to everyone. I welcome you to the joint GLI-GDI workshop, Access to Diagnostic, Treatment, Care, and to end TB. My name is Elisa Tagliani, and I will be chairing this workshop. Before we start, I have the pleasure to introduce my co-chair, Dr. Sarabjit Chadha. Dr. Chadha is an infectious disease clinician by training with over 15 years of experience treating TB, including drug-resistant TB and public health. He has worked with the union heading the TB and communicable disease unit for Southeast Asia, and he currently is working with FIND as regional technical director for India and Southeast Asia. In addition, he serves as the chair of the Global Drug Resistant TB Initiative, and is also a core group member of the Global Laboratory Initiative. Sarabjit, the floor is yours.
Thank you, Elisa, and a warm welcome to all the participants to this joint GLI-GDI workshop on access to diagnostics, treatment, and care to end TB. So as you're all aware, you know that TB detection, treatment, and care of individuals with TB continues to remain a challenge, particularly, you know, in high burden settings with limited resources and weak healthcare infrastructure. The problem has been compounded recently with the unprecedented COVID-19 pandemic, which has added more complexities and more stress to the already weak health systems worldwide. And this has hampered the progress in fight against TB significantly. The Global Lab Initiative and the Global Drug Resistant TB Initiative are working towards strengthening lab and clinical management capacity for programmatic management of TB. Through this workshop, you know, we will explore the challenges encountered in countries and steer the discussion on how to address these to not only protect, but also to sustain progress in the fight against TB. The workshop will have a few presentations, followed by breakthrough sessions and a plenary. So I would now hand it over to my co-chair, Elisa, who's a senior research scientist at San Rafael Institute in Milan. And she is the chair of the Global Lab Initiative since 2020. Over to you, Alyssa.
Thank you, Sarabjit. So I have the pleasure to introduce the speakers, our speaker for today. The first presentation today will be delivered by Dr. Matteo Zignol, who is the head of the TB Prevention, Diagnosis, Treatment, Care, and Innovation Unit at the WHO Global TB Program. Dr. Zignol leads the work on the development of new policy for universal access to diagnosis, treatment, and care, as well as helping shape the TB research agenda and innovation. Next, we'll have a presentation by Dr. Patricia Hall, who is the team lead for the TB and Clinical Monitoring Team, International Laboratory Branch at US CDC. She's also the head of the WHO Supranational TB Reference Laboratory in Atlanta. Patricia is also the vice chair of the Global Laboratory Initiative and the chair of the newly established WHO Technical Advisory Group. Next, we will have a presentation by Dr. Zwapna Uplekar, who is a scientific officer in the sequencing team at the Foundation for Innovative New Diagnostic Find. Her work focuses primarily on the strengthening of next-generation sequencing capacity in low-middle-income countries. Then we'll have a presentation by Dr. Brian Citro, who is a human rights lawyer, independent researcher, and technical consultant for Stop TB Partnership and the UNPD DP HIV Health and Development Team. And finally, we'll close our presentation with Dr. Ignacio Monedero, who is a medical doctor with extensive experience in the TB field and member of the Global Drug-Resistant TB Initiative. Dr. Monedero also provides technical support to several countries in the Eastern Mediterranean region of WHO via the Green Light Committee mechanism. And so now, without further ado, I will give the word to our first speaker. Matteo, please. Thank you.
Thank you very much, Elisa, for the kind words of introduction. And I hope you can see my screen.
Yes.
Good. Good morning, good afternoon, and good evening, everyone. I'm delighted to be here today to present on updates on the WHO guidelines. I declare that I do not have a conflict of interest to report. And as I said, the topic of this presentation is to give a brief update on the new guidelines on TB detection and treatment. First of all, I like to say that from this year, all work of WHO related to the guidelines, the implementation guide, the training, is hosted in one single platform where you can find everything WHO has sort of recently recommended in the area of TB prevention, screening, diagnosis, treatment, and care. The platform is composed of three areas. One is on consolidated guidelines. The second one are the implementation guide, operation handbooks. And the third one is a training catalog. I really invite you to go and check this new platform. This allows you not really to not to search for information in the WHO website, but really go in a place and find everything you probably will need. As I said, apart from the guidelines, the handbooks, and training, there is a function to search for topics and also search for recommendations. I just want to show you one slide on the searching function for recommendation, which it's called RecMap. Here you can search for recommendation in a free text, or look by areas. And here you'll really find all the latest and most recent recommendations. We do also have a mobile app which goes with the platform, which is going to be also available offline, where you can really find everything that you see on the platform website. So it's a very handy sort of app, which I encourage you to download if you don't have it already. And as I mentioned earlier, in addition to the guidance, to the guidelines, and to the implementation guide, there is a section on training material, which is going to be, I think, by the end of November, we will see the first 3 training materials on diagnostics, TB prevention, preventive therapy, and treatment of drug-resistant TB. So all the work of WHO when it comes to policy guidance is structured now in 5 modules. The first one is prevention. The second one is screening. Third one, diagnosis. Fourth one, treatment. And the fifth one is on vulnerable population, comorbidities, and people-centered care. And for the purpose of the discussion today, we will focus on module 3 and 4, so on diagnosis and treatment. Let me start with the latest guidance on diagnosis. This was issued this year, actually in early July, and it's one consolidated guidance for everything that you would like to see in terms of recommendations from WHO on TB detection for TB and drug-resistant TB. And the new elements that have been introduced in the latest guidance of 2021 are 3 sort of sets of recommendations that are looking into new classes of technologies. So WHO is not going to be recommending single technologies anymore, as we were doing before in the past few years. We are making a recommendation for a class of technologies, and within the class there are multiple, of course, products that can be used. In most cases, multiple products. In some cases, unfortunately, still one product. So let me go through the novel recommendations. The first one is moderate complexity nets for the detection of TB and rifampicin resistant and INH. These are, it's a class composed at the moment of 4 products, as you can see in the slide: Abbott, Real Time, BD-Max, the Hain Prototype, and the RTB, and the Roche. And this class of technologies is recommended for patients with pulmonary TB on respiratory samples, and for the detection of rifampicin resistant and INH resistant. And it will replace culture and DST. So it's not a follow-on sort of class of tests, but it's a replacement for culture and DST. The second major recommendation is a low complexity automated net for the detection of quinolone resistance and INH. This is actually it's a class recommendation, but we at the moment have only one technology, which is the Expert MTB XTR assay. Again, this class is recommended for use in patients with pulmonary TB for the initial detection of INH and second-line resistance, including the quinolones. And then the third new recommendation is on the high complexity reverse hybridization-based nets. And this is actually a class, but it's again one single product, which is the Scholar PZA-TB from Nippon. This is for the detection, of course, of PZA resistance. There are more sort of news that we would like to share with you. We have established a new task force, advisory group, task force on TB diagnosis and laboratory strengthening, which will help WHO in providing guidance on a large range of topics. We are planning 2 meetings. One we had it last week on the bioequivalence of GeneXpert 6 versus 10 color cartridges, modules. And the next one is coming up at the end of October is on the commercial blood-based in vitro eGRADs. We have plans for 3 GDGs, guidelines development group meetings in the next year on skin test for the detection of TB, on next generation LAMP, and on next generation sequencing. And then just to conclude this part on diagnostics, I'd like to mention 3 important documents that we issued this year in the summer. It's the first one that you see on the left-hand side is the first edition of a catalog of mutation in MTB complex and with their association with drug resistance. This is an important tool to help interpret the role of genetic marker of resistance in relation to phenotypic resistance. The second document is an update on the critical concentration for drug resistance to INH and rapamycins. And the third one was developed in close collaboration with the new diagnostic working group of the Zwapna partnership, and is a target profiles for next generation DST at peripheral centers. Let me now move on the treatment side, which is extremely busy. We have been consolidated guidance both on drug susceptible TB and on drug resistant TB. On drug resistant TB, you probably have already seen the first consolidation in 2020. We are going through a revision right now. We do have a guidelines development group meeting in early next year, and I will discuss that in a moment. And for drug susceptible TB, again, we are issuing the first consolidated guidance now, actually in the next couple of months, probably early next year, which will include recommendations and consolidated recommendations from previous editions of guidelines, plus, of course, new recommendations on shorter regimens for the treatment of drug susceptible TB. As I mentioned earlier, just now, we have 2 new regimens, shorter regimens that have been reviewed by WHO this year. We have already communicated some of the results of the WHO assessment through rapid communications. One is a 4-month quinolone-based regimen with rifampicin. It's the results of the study 31 led by the US CDC and NIH. And the second regimen, and this is for adults, and the second regimen is a 4-month regimen for children, which is the outcome of the SHINE trial. When it comes to drug-resistant TB, there are very important new data that is going through WHO assessment right now. We are reviewing the results of the practical data on BPAL-M. You probably are all aware of the announcement by MSF of the results of this trial earlier in spring. We will update all oral regimens for MDR-TB, and we are envisioning an update on BPAL for patients with pre-XDR-TB. This year, we, apart from the guidelines, we have issued very important documents, a revised XDR definition, a revised outcome definitions for the treatment of drug-resistant tuberculosis. We've conducted a systematic review on first-line medicine, dosing in children and adults, which will become available very soon in November. We are updating the definition and reporting framework, and we have started working on a revision of the target regimens profiles for TB treatment. This is a document that was issued in 2016 and merits a revision. I think I'll skip this one. I'll just move to the next one, which is talking about it's a mapping of treatment regimens, and you can see treatment regimens are shortening. Every year or so, we get new data and we assess new data, and hopefully we will continue this trend to get always shorter treatment for TB and also drug-resistant TB. And last but not the least, another important word related to our policy is that we have revised the framework on the drug-resistant TB individual data platform, which is a sort of database that collects individual patient data to make to assess new regimens and new formulations. And this data set will be becoming available to those who want to analyze it. At the moment, so far it's been a closed database, almost, and the next step will be to make it really openly accessible to researchers. I think that's all from my side. I want to acknowledge a large group of colleagues who have been leading on these areas, and you see the names on the slide right now. Most of these colleagues are actually attending this webinar, and I'm sure they will be pleased to answer with me your questions. Thank you very much for your attention.
Thank you very much, Matteo. And now we'll have the second presentation by Patricia Hall. Patricia, the floor is yours.
Thank you so much, Elisa, and thank you to the audience for taking the time to join us today. Can you hear me okay?
Yes.
Wonderful. Okay, I have no conflicts of interest. So, according to the 2020 WHO Global Report, of the 10 million estimated incident cases of TB in 2019, pre-COVID-19, approximately 7 million were notified to WHO by national TB programs. Unfortunately, of those, only 4 million, or 57%, were bacteriologically confirmed using a TB diagnostic test. And despite the recommendation for all presumptive TB cases to receive drug susceptibility testing to at least rifampicin, only 2.2 million, or 61% of the notified cases, received RIF-DST. And of the roughly 200,000 patients diagnosed with rifampicin-resistant and/or multi-drug resistant TB, only 143,000, or 71%, received further susceptibility testing for at least the fluoroquinolones. These data highlight continued global gaps in patient access to WHO-recommended diagnostic and drug susceptibility testing services. However, in good news, as was just covered by Matteo, to strengthen TB testing programs, this year WHO substantially expanded the landscape of recommended TB testing technologies, recommending C-reactive protein and expert in TB-RIF as TB screening tests for the first time, recommending additional molecular TB diagnostic and drug susceptibility tests to aid in TB diagnosis, including 5 new instrument-based testing systems, and recommending sequencing-based strategies for drug-resistant TB surveillance, thereby expanding options for both centralized and decentralized TB testing strategies to benefit patients, clinicians, TB-affected communities, and TB disease control programs. Of note, WHO also adopted the new test classification scheme this year for the recently endorsed molecular and diagnostic drug susceptibility testings that was just nicely described by Matteo, where technology classes, highlighted on the left side of the table, are defined by the level of test complexity from low to high, technology types such as automated and hybridization-based nucleic acid amplification tests, or NATs, and target conditions for use, such as resistance to RIF and INH or PZA, for example. As Matteo reviewed, class-wide recommendations for test use are now available. For details on the new molecular WHO recommended diagnostic tests, WHO recommendations for use, performance characteristics, their equipment, supplies, and reagents, as well as operational and implementation considerations, please see the GLI and WHO information sheets included in Annex 2 of the 2021 WHO Module 3 TB Diagnosis Operational Handbook. So importantly, these new testing options bring opportunities for TB testing network customization. For national and subnational TB programs, communities, and patients, where all MWRDs have good sensitivity and specificity for detection of Mycobacterium tuberculosis complex. Additionally, most, but not all, MWRDs that detect TB can also detect drug resistance-associated mutations. Among those with this DST capacity, all detect RIF resistance, some detect both RIF and INH resistance, and some detect RIF, INH, fluoroquinolone, and additional resistance-associated mutations. Lastly, all MWRDs and their associated equipment and instrumentation vary in technical specifications and requirements, not just in assay complexity as captured by the new technology class scheme, but also in capacity, testing turnaround times, infrastructure needs, and other practical considerations. So how might you go about selecting one or more MWRDs for setting-specific implementation? So let's go through an interactive thought exercise together before we review the new GLI tool. Our union workshop organizers are helping today, and they will launch a poll now for you to kindly complete anonymously. The poll question is, which of the following would you use to guide selection of MWRDs for your setting? And please note that you can select all that apply. Your options are local TB and DRTB epidemiology, national policies and strategic plans, existing testing network design, current and planned specimen referral systems, and or availability of local technical support. You'll have up to 30 seconds to complete the poll. Please respond now. Hopefully everyone can see the poll. We have a couple of responses in. Please feel free to participate. There are no wrong answers here. Okay.
Poll disappeared very fast.
Has it already disappeared? Oh, it ended already. I see.
Yes.
Thank you. Thank you for letting us know. Thank you for relaunching to our union colleagues. Ah, there we go. The responses are rolling in. Wonderful. This is great to see. We'll give it a few more moments here for others to participate. Okay, maybe 5 more seconds before we close it. Thanks to those that have had a chance to complete. I know the question is a bit long and the poll goes a bit quickly. It's for the sake of time today. Thank you for ending the poll. Okay, can we share the results, please, back with the audience? Hopefully people can see these now. So it looks like the majority of participants say that they would use national policies and strategic plans, followed by local TB and Drtb epidemiology, existing testing network design, then the availability of local technical support for operational support of tests and instruments, and lastly, current and planned specimen referral systems. So this is great. It's a great snapshot to see among all of our users what you would go to. In our view at GLI, we've developed the tool that I will go through today that incorporates all of these aspects and considers how each of them may be considered when trying to identify suitable MWRDs. Okay. I'm going to stop sharing those poll results now. Can everyone see my slides again?
Yes.
Great. Okay, so let's get into the tool. GLI has recently developed a tool to address this question. It's entitled the Manual for Selection of Molecular WHO Recommended Diagnostic Tests for Detection of TB and Drug-Resistant TB, focusing on the molecular tests. The manual presents a stepwise process for suitable MWRD identification and selection that's driven by setting-specific diagnostic testing needs. It considers the ability of recommended MWRDs to meet a setting's testing needs based on factors like national policies and strategic plans, epidemiology, the design of the testing network, and the availability of specimen referral systems. And lastly, the guide assists users to consider feasibility of suitable MWRD implementation based on practical considerations, such as each setting's registration and importation requirements, supply chain structure, service and maintenance needs, and availability of local and technical support for assistance for test introduction and operation. So you'll see all of those full components incorporated here. So the manual incorporates a background section with an introduction and manual scope discussion, 3 separate parts that review the stepwise process, and 2 annexes that serve as practical resources for the stepwise process. We'll now take a quick tour of the contents, starting with the tests included for selection. As discussed in the background section of this document and shown in the table here, the GLI manual focuses on selection of initial molecular diagnostic tests for diagnosis of TB without drug resistance detection, shown under the yellow heading in the table, and with drug resistance detection under the green heading. While follow-on molecular diagnostic and drug susceptibility tests listed under the blue heading are considered as part of the initial test identification and selection processes. It's important to note that while this manual only focuses on MWRDs, culture and phenotypic DST remain crucial for TB treatment monitoring and DST for the new Group A drugs for which MWRD-based DST is not yet available. Linkages from initial MWRD testing services to culture laboratories should also therefore be carefully considered as part of a holistic testing network. Okay. So let's review the stepwise process presented by the manual that does focus on the initial MWRDs. First, pre-selection data are needed for some initial analyses. This includes data from national strategic plan policies, targets, goals, and priorities shown in orange, local, national, and subnational drug susceptible, resistance, co-disease, and pediatric TB epidemiology as highlighted in the yellow square, data for the number and location of persons needing testing, as well as testing sites and linkages between them for diagnostic network analysis, shown in red, and data for testing site resources that outline infrastructure, electrical, environmental, storage, and other resources, including human resources, shown in blue. Once collected, the National Strategic Plan and EPI data are used to identify needed MWRD capabilities, with an emphasis on whether detection of TB and/or detection of any specific drug resistances are needed. National Strategic Plan, EPI, and network analysis data are also used to identify gaps in client access to needed testing services geographically and by resistance patterns, with opportunities to strengthen client access to testing within established turnaround times. These data are also used to estimate site-level expected workloads. Widespread gaps identified in this category of analyses may also indicate that the user's network would benefit from a wider geospatial mapping-based diagnostic network optimization exercise, which is also touched on in the manual. And lastly, shown here in the final box, testing resource data are used to identify both the capabilities and resources of each existing or potential site that would be required to support low, moderate, or high complexity testing according to new WHO technology classes. These data may be combined with workload or other data to inform practical considerations for test selection and implementation. So all of this data is collected and some initial analyses are completed, and the data is used then to inform each step of a multi-step decision pathway for the identification of suitable MWRDs. So first, and apologies, I know this is a bit small, hopefully you can see it well. Diagnostic network assessment data that used and gathered in the pre-selection process are used to identify specimen collection sites and determine whether or not they have functional and efficient specimen referral systems to access needed testing services. If not, the user is prompted to consider improvement or establishment of referral systems or establish on-site testing services depending on the patient need for that particular site. All these collection site and referral data sets are then combined for each testing network MWRD testing site. So now we're talking about testing sites. Then the National Strategic Plan and EPI pre-selection data are used to determine whether each site requires detection of TB, shown in yellow, detection of TB and RIF resistance, shown in green, or TB, RIF, and other resistances, shown in blue. EPI and diagnostic network analysis findings can then be used to inform whether the testing site requires low or high throughput testing services to meet patient demand for the test type selected. And by further considering test site resource information, the site may be classified as suitable for low or moderate complexity testing, for example, as shown here in the lowest level of boxes. At this point, suitable MWRDs are listed for each column of the pathway, each of which may require follow-on testing highlighted by the gray box at the bottom of the schematic that should be considered to ensure TB-positive patients receive holistic testing services. However, keen observers on this tour will note that the decision pathway ends in a listing of multiple suitable MWRDs to meet each site's need for each category. These will, of course, require cross-comparison for selection of one or more testing technologies for implementation. It may not always be one selected. And this is where part A3 comes in of the manual with considerations for suitable MWRD implementation. This section proposes that users review their network-wide and site-specific lists of suitable MWRDs selected using the pathway, alongside country-specific considerations for finance, import and regulations of tests and associated equipment and instrumentation, infrastructure and human resource requirements, instrument and test specifications, as well as end user values and preferences for both the tests and the testing experiences. And these considerations are well supported by the manual's annexes, where Annex 1 presents specific questions designed to compare and contrast similar MWRDs that cover the WHO recommendations for suitable MWRD use, costs associated with the test instrumentation, commodities, costs associated with test operation and cross-disease program sharing, procurement and supply chain requirements, service and maintenance of testing instruments and the ancillary equipment, testing site-specific requirements for test installation and operation, and human resource requirements that impact available or planned testers and may also lead to the need for cross-disease program sharing and communication. In addition to Annex 1's questions, Annex 2 supports comparison of suitable MWRDs by presenting a table, a portion of which is shown here, that lists test-specific specifications, technical specifications in this case, according to WHO and manufacturer documentation. Each specification in the table was selected for inclusion based on its variability between or across test types, helping users to understand the practical aspects of test introduction and implementation. such as each instrument's maximum capacity to meet more detailed throughput needs within the low and high categories presented in the decision pathway, and differences in test run times that may impact result turnaround times. Lastly, Part B supports manual users with a comprehensive list of suggested readings and further learning resources, including the WHO policies, normative documents, GLI implementation documents, information sheets and toolkits, and various sources of information on diagnostic network analysis, as well as diagnostic network optimization, while Part C includes references with hyperlinks with reference. And lastly, we are really excited about this new tool. It's currently in the final stages of development. We look forward to sharing the document with you by the end of the year and providing an overview of the final publication via a GLI webinar next year. So please stay tuned for more and sign up to receive email alerts from the GLI listserv for releases and event dates. At last, I'd like to thank Dr. Tom Shinnick as the contracted lead author for this manual, Elisa Tagliani as our GLI chair that oversees our full scope of GLI work, our WHO Secretariat, the GLI workstream members that have weighed in on this product and helped with the design and the final review, as well as the remaining GLI corporate members. Thank you very much.
Thank you so much, Patricia. Excellent presentation. And I will just remind everyone that you can either type your questions in the chat or ask them directly to the speakers at the towards the end of the workshop. There will be a question and answer session. So now I'm pleased to introduce the next speaker, Dr. Zwapna Uplekar, who will be presenting on the practical consideration for implementing next generation sequencing in national TB programs. Over to you, Zwapna. Thank you.
Hi, everyone. Good afternoon. My name is Zwapna Uplekar, and in this presentation, I'll talk about the practical considerations for implementing next generation sequencing in national TB programs for surveillance of drug-resistant TB. I have no conflicts of interest to disclose. So as we all know, delays in the diagnosis and treatment initiation for drug-resistant TB are among the biggest challenges to TB control and elimination worldwide. In 2018, less than 40% DRTB cases were diagnosed, of which under 14% were cured. In 2019, there were over 10 million TB cases, of which 15% were resistant to at least one first-line drug. Drug susceptibility testing is a necessary step to determine the appropriate and effective treatment for a patient's TB infection. As a priority of patient-centered TB care, the WHO's End-TB strategy calls for universal access to comprehensive drug susceptibility testing for all persons with any form of TB. This should allow for early diagnosis and treatment and drastically improve clinical outcomes for DRTB. I assume everyone in the audience is familiar with next-generation sequencing technologies. NGS technologies rely on rapid and high-throughput methods to determine a part or an entire genome sequence of an organism. Unlike rapid molecular diagnostics that target only the most common mutations in a couple of genes, NGS allows interrogation of hundreds of mutations in multiple genes. Moreover, NGS is comprehensive and can overcome limitations of phenotypic testing, such as long turnaround time and need for stringent biosafety requirements. This makes NGS suitable for surveillance as well as diagnosis of drug-resistant TB. I'd like to provide a brief overview of the two main NGS methods that are relevant for TB. Whole genome sequencing, as the name suggests, is used to determine the entire DNA sequence of an organism. Targeted sequencing, on the other hand, is used to determine sequence of specific regions in the genome when whole genome sequencing is not required or not possible. In the case of Mycobacterium tuberculosis, WGS works best with bacterial DNA extracted from culture isolates. On the other hand, TNGS involves selective amplification of regions of interest in the DNA, and therefore it requires less amount of DNA and can work directly from DNA extracted from sputum samples. While WGS covers the entire genome, the depth of coverage is typically lower than NGS. Also, given the large amounts of data generated, WGS has more complex bioinformatics and data storage needs compared to targeted sequencing. That said, the overall sequencing workflow involves the same key steps. It starts with extracting DNA from an MTB bacteria recovered from a clinical sample or culture, followed by processing of the DNA to generate a library of DNA fragments. This is then sequenced on one of many instruments that are available commercially at the moment, and finally using bioinformatics tools to assemble the sequences and compare them to a reference strain in order to identify variants or mutations. NGS not only has the potential to expand comprehensive DST, but also to transform the diagnosis and treatment of DRTB. NGS can help detect mutations known to confer resistance to rifampicin as well as other first and second line drugs, and thereby categorize a strain as drug resistant or susceptible. It can help assess the prevalence and emergence of mutations conferring resistance in a population. It can provide information on genotypes of MTB strains circulating in the community, as well as data on transmission dynamics, including outbreak identification. Whole genome sequencing in particular can help identify novel mutations and resistance conferring loci to support development of new diagnostic tests or improvement of existing tests. While targeted sequencing can provide faster, safer, and more comprehensive results compared to phenotypic DST to inform patient care decisions and design effective treatment regimens. In order to be an effective approach for DRTB surveillance, NGS-based DST requires a comprehensive knowledge of the genetic determinants of phenotypic resistance so that the sequence data can be accurately interpreted and used to produce a drug resistance profile. A major initiative involving FIND, the WHO, and the Cryptic Consortium in the past year, as well as other stakeholders, involved compilation of high-quality phenotypic DST and standardized sequencing data, developing a standardized bioinformatics pipeline for variant detection and annotation, and establishing a validated statistical approach to associate variants with phenotypes. This led to the development of the first global TB mutations catalog to predict drug resistance from genetic data. The catalog provides guidance to assess the clinical relevance of any detected mutation and harmonizes the interpretation of mutations identified using NGS and other molecular tests. The screenshot below shows how mutations are presented in the catalog. Based on the sensitivity, specificity, and the positive predictive value, each mutation has been assigned a confidence grading to indicate whether it is associated with drug resistance. All of the background that I just presented has been published by the WHO over the last few years. The technical guide on the use of NGS for detection of mutations was published in 2018 and provided an overview of NGS methods and workflows, as well as a comprehensive review of the scientific evidence on characterizing the genetic basis of drug resistance to major anti-TB drugs. More recently, in 2020, the WHO guidance for surveillance of DRTB recommended the use of NGS technology for molecular DST and its inclusion in lab testing algorithms for DRTB surveillance. The latest guidance that I mentioned on the previous slide was the 2021 catalog of mutations in MTB associated with drug resistance. So what's coming next? We've been working with the WHO on an implementation guide to support countries in planning and implementation of NGS-based approaches, primarily for surveillance of DRTB. It follows up on the guidance document that I showed on the last slide. The starting point for the implementation guide assumes that the country has designed a DRTB surveillance system that meets its current and projected needs for DRTB surveillance and has decided to incorporate the use of NGS-based DST in a periodic survey or a continuous surveillance system. This document includes guidance on how to determine the intended use of NGS based on objectives of the National DRTB Surveillance System and National TB Strategic Plans, how to assess country readiness for implementation, how to manage supplies, forecasting, procurement, and distribution, how to assess readiness at the level of specific sites and laboratories, involving including setup of sequencing infrastructure, how to validate NGS protocols, establish quality assurance mechanisms, and how to build capacity among technical and program staff, as well as finally a framework to measure the impact of NGS-based DST. The target audience for this guide are NTP staff, MOH officials, implementing partners, and basically everyone engaged in DRTB surveillance, lab strengthening, and program support. Over the next 10 minutes or so, I'll provide an overview of what one can expect in this guidance document. It includes the key components that are listed in this figure, and I'll go through these one by one in brief. The first step in country planning is to establish a technical working group to lead the planning for implementation. The group will define the intended immediate and future use of NGS for DRTB surveillance in the country. This will have important implications on choice of technologies and equipment to use, as well as the selection of sites for testing, specimen referral systems, and target turnaround times. The group will also be responsible to perform a situational analysis and develop a costed operational plan with timelines and milestones. The supporting resources provided in the guide to help with country planning are listed here. These include a checklist for NGS implementation, recommended roles and responsibilities for the technical working group, criteria for technology selection, checklists for situational analysis, as well as considerations to guide budget development. An important step prior to NGS implementation is to update existing DRTB surveillance protocols to incorporate NGS. The implementation plan will depend on which drugs will be included in the surveillance activities, as certain new and repurposed drugs would still require phenotypic DST. The testing algorithms, as shown here, may or may not include phenotypic DST. In general, the starting point for any algorithm used for DRTB surveillance is the collection of a specimen from a patient with bacteriologically confirmed TB. From this point, the algorithms diverge depending on whether targeted sequencing or whole genome sequencing will be used. For TNGS, the specimen can be referred directly from the TNGS testing site for sequencing purpose, for the sequencing process, whereas for WGS, a bacterial culture is typically needed. The algorithms come back together at the end at the data analysis step, where data generated can be used for DRTB surveillance. The average turnaround time for TNGS is less than 2 weeks, while for WGS, it's just over 4 weeks. The next step is setting up the infrastructure, which involves several different aspects. First is to ensure compliance with relevant regulatory processes and procedures. Countries should work closely with manufacturers to determine importation and registration requirements and enable initiation of country verification studies as needed. An essential step of the implementation process is the selection of an appropriate sequencing instrument to fit the needs of the clinical lab designed to perform the desired NGS applications. NGS instruments differ widely in chemistry, throughput, price, time to completion of a sequencing run, as well as NGS read length. Details of the most common commercially available solutions are also presented in the guide. Next step is to ensure uninterrupted availability of reagents by implementing forecasting, ordering, and distribution procedures to ensure a reliable and timely supply of quality assured reagents and consumables. The supporting resources provided in the guide to help with infrastructure setup are a list of essential equipment and reagents required for NGS, as well as an installation checklist and resources. Then, a well-trained workforce with the knowledge, skills, and abilities to conduct all aspects of sequencing are critical for the success of any implementation strategy. The guide provides details on how to define the roles and responsibilities of key staff, recommendations on the training curriculum for lab staff, and approaches to assess competency. It also includes suggestions on potential ways to provide post-training mentoring and support. The supporting resources provided in the guide to help with country planning are the ones listed here. So the terms of reference for key staff, agenda for training programs, as well as criteria for competency assessment. Next is the development of essential documentation and procedures needed for lab and data management. For laboratory testing, this includes development of SOPs related to specimen collection, processing, referral, DNA extraction, library prep, sequencing, and so on. For data, a robust data storage and computing infrastructure is essential to manage the massive amounts of data generated by NGS technologies. In addition to the technical requirements, it's also important to develop procedures for data security, sharing, and ensuring confidentiality. The supporting resources in the guide to help with technical procedures are a list of SOPs related to lab testing, as well as information on estimated data storage needs based on the anticipated NGS workload. Moving on, a comprehensive quality assurance or quality management program is needed to ensure accuracy, reliability, and reproducibility of lab results. For this, the supporting resources provided in the guide include a list of essential elements of a quality assurance system, key quality indicators and quality control considerations for NGS workflows, examples of proficiency testing programs for TB and GS, as well as recommended data and quality indicators for NGS-based DST. Last but not least, during the initial phases of planning, countries should establish a set of key indicators or milestones that can be used to monitor the implementation process. A framework for monitoring and evaluation of the impact of NGS will be essential to inform treatment decisions moving forward. Typically, a key objective of implementing NGS-based DST is to provide completeness of the DST results recorded in the Drpb surveillance system. The supported resources provided in the guide for monitoring and evaluation are a list of key indicators to monitor the NGS implementation process, as well as examples of impact measures and outcome indicators. Finally, the type of information being recorded and reported in the Drtb surveillance system is very important. Depending on the current format of the country's data collection tools and test requisition forms used in Drtb surveillance, revisions to accommodate NGS testing may be necessary. The analysis defined in the Drtb surveillance protocol should guide what information will be included in the NGS report form. The guide provides supporting information in the form of examples of NGS-based DST reporting forms. In terms of sharing the data, countries are encouraged to submit data to the WHO sequencing database that is currently in development. This brings me towards the end of my talk. You may notice that the guide does not address implementation considerations for the routine use of NGS-based DST to guide patient care decisions, as the global policy for this potential use has not yet been developed. However, efforts are currently ongoing in this area. The Seek and Treat project is a multi-year unit funded project co-led by the FIND and the WHO with the goal of establishing targeted sequencing as a diagnostic tool for Drtb. This project involves performance evaluation of targeted sequencing workflows to generate evidence to support WHO policy on the use of NGS solutions. It also involves the development of a TB knowledge base that I mentioned in the previous slide. This database is intended to act as a global repository for storage of genomic and phenotypic DST data to support standardized analysis of NGS data and associated metadata, and to facilitate maintenance and update of the WHO catalog of drug-resistant mutations that was published earlier this year. Thank you for listening. I hope you found this brief overview beneficial. Please share any questions or feedback you have at this stage in the chat box. And as I mentioned, the guide will be published in the next few months, and we hope it will be widely used. I would like to thank the organizers of the symposium for giving me the opportunity to present, as well as the team behind the development of this guide. Thank you very much.
Thank you very much, Zwapna. Excellent presentation. So I'll give the word to my co-chair to introduce the next speakers. Thank you. Sarabjit, are you there? Well, so I will introduce the next speaker for today is Dr. Brian Sitoro, who will present on the legal and policy solution to NTB, drug-resistant TB, an assessment of 10 high-burden countries' fulfillment of the UNHLM legal commitment. Thank you, Brian, and welcome.
Hi, welcome. Let me start sharing my screen. Okay, so it's great to be here today. I assume that you can all hear me and see me. I'm not a doctor, by the way. I am a lawyer. I'm a human rights lawyer, and I've been a law professor here in Chicago for 7 years and a researcher. So I may be the only lawyer speaking today, which won't be surprising that what I'm here to talk about are the legal and policy solutions to end DRTB. And this is original research that is supported by the Global Drug-Resistant TB Initiative, of which I'm a part. And what I've been doing for about the last year and hope to publish probably early next year as I finish up over the next month or so, is an assessment of 10 high-burden countries' fulfillment of their commitments under the UN high-level meeting around law and policy, so the legal and human rights commitments. So I have no conflicts of interest. So in essence, what this study is about is really accountability for the United Nations high-level meeting legal and human rights commitments. So there are 3 key commitments of this kind, although there are arguably others. But the 3 that I've chosen to focus on, because I think they're probably the most explicit and maybe the most important, are the right to health, non-discrimination, and access to medicines. So this is where they come from and what they are. Excuse me. So the right to health comes from paragraph 37 of the UN Political Declaration. So I should take a step back and say, these commitments and targets, as all of you know, all the commitments and targets from the high-level meeting are in the UN Political Declaration that is a result of that meeting. So it's the same with these. And so the right to health, the way that it's defined, or I'm defining it based off of the Political Declaration, is explicit recognition and commitment of the right to health. So this can be found in the Political Declaration in paragraph 37. Then non-discrimination, is defined as explicit prohibition of discrimination against people affected by TB. And this is in paragraph 37 as well. And then the third commitment or target that I'm looking at is a commitment to promote access to affordable medicines through intellectual property law in line with the WTO, which is the World Trade Organization, Doha Declaration on the TRIPS agreement. So again, this is directly from the Political Declaration. This is from paragraph 19 in the Political Declaration. So these are the 3 commitments or targets that this assessment is looking at. And then what I'll go over now for the rest of the talk is what's the scope of this assessment? What are the countries and the sources of law that I've looked at to determine whether countries are complying or fulfilling their commitments? And then what's the methodology? And I will introduce and explain an index that I've created, which I'm calling the Legal Rights Index. And then I will share the preliminary assessment results. So both for the target indices for each of those 3 commitments, right to health, non-discrimination, and access to medicines, and then the overall assessment results for the Legal Rights Index. Sorry, I'm just trying to move, there we go. Okay, great. So what is the scope of this assessment? So there's 10 countries with high burdens of DRTB that I'm looking at, and that's MDRTB and RRTB. So it's a review of those countries because they account for about 80% of the global drug-resistant TB treatment gap. So those were chosen because of the treatment gap, and they are China, the DRC, India, Indonesia, Myanmar, Nigeria, Pakistan, Philippines, Russia, and Vietnam. So these are the 10 countries that are part of the assessment. Okay, so because these are legal and human rights commitments, the next critical scope of the study is to determine, well, where am I looking? What am I reviewing to determine compliance or fulfillment with the targets and then the commitments? So that's what we call sources of law. So what are the sources from which law arises that we can look to determine whether or not countries are doing what they said they would do with regard to law and human rights? So the first target is the right to health target. And I'm going to go through each of these, each of the 3 targets or commitments and show you what the sources of law are, and then share the definitions that I've developed for the assessment. Okay, so the sources of law for the right to health, it's broken down into 3 categories, and you'll see that as it goes to the right, it gets a little more specific. So there's constitutional recognition, there's statutory recognition, and executive branch recognition. So what does that mean? It means that one of the sources of law, the top source, is in the Constitution. The second is in legislation or statutes, which is the same thing. And then the third would be from the executive branch. That's like policies, directives, et cetera, things that might be promulgated by the Ministry of Health or Ministry of Justice, et cetera. And then in order to do 2 things: one, to acknowledge and recognize the various degrees of recognition, and 2, to kind of give credit where credit is due to the countries, there's a further disaggregation or subdivision of each of these categories, and it's the same for each target. So for constitutional recognition, there is full recognition, and then there's partial recognition. And you'll see that the score goes down, and I'm going to explain the scores in a second, but each target, each commitment has a possibility of scoring 1, and that would be a perfect score. So you'll see that it goes down from 1 here down to the lowest, which would be 0.15. And that would be full recognition of the right to health in line with the UNHLM, down to much lesser recognition. So statutory recognition is also broken up. There are health or human rights laws, there's HIV laws, and then the executive branch recognition is just understood broadly. And you can see the scores that are associated with each of those subdivisions. Now, I'll show you here, I won't do this for each one because it'll be a bit much, but I'll show you the definitions of each of those subdivisions. So first, for constitutional recognition, what it means is that there's an establishment of the right to health in the national constitution of the country. Full recognition for the full point, or 1.0, is, or requires rather, explicit, unambiguous language that establishes an individual right to health. Partial recognition includes judicial recognition of a constitutional right of a right to health in the absence of explicit recognition in the Constitution, or a state commitment in the Constitution to protect or promote individual health or public health, but without the explicit creation of an individual right. Now, if that sounds like splitting hairs and maybe slightly complicated, I sympathize with you. These subdivisions are a result both of this assessment, but also my experience as a human rights lawyer and as a researcher around health and other areas of law and rights. And this is generally how constitutional rights are recognized. Obviously, they can be written into a constitution, but in many countries, one example would be India, the courts can recognize constitutional rights, as they've done in India for the right to health. And therefore, it's a judicially recognized constitutional right. And then thirdly, in many countries, the Constitution commits to or recognizes a principle that involves the right to health, about protecting or promoting health, but it's different than an individual right. And if you have questions about that, we can talk about it. But so that's why there are these subdivisions. Statutory recognition means explicit, unambiguous establishment of a right to health in basically different kinds of legislation. So in national health or human rights legislation, that's for 0.5 points, that would be better than in HIV legislation. But because TB and HIV are so closely connected, and because there's much more legislation that's specific to HIV, I've decided to recognize when a country explicitly creates a right to health in the context of HIV legislation. The other thing, the reason for that is that you never know how activists, lawyers, and the courts may take something from over here and start to apply it over there. So it's meaningful to have a right to health, even if it's not in the Constitution, in legislation such as HIV legislation, et cetera. And then so executive branch recognition means the explicit recognition of the right to health at the national level. So not in a city or not in a state or a province, but at the national level. That's from an executive branch policy, a strategic plan, a directive, et cetera. I mean, there's those of you who are familiar with how executive branch policies work, there's lots of different kinds. And so this, by the way, would include a national strategic plan. So if the Constitution and then the legislation in a country does not recognize the right to health, but the national TB program has said, people with TB have a right to health, or if it just said there is a right to health, I credit the country for 0.25 points because that is meaningful, though obviously not as important as constitutional recognition. Okay, so that just gives you a sense of how and why there are subdivisions under the sources of law for each of the targets. I'll talk quickly about the other two targets, but I won't go. I'll just show you, but I won't go as into depth with the definitions. So the non-discrimination targets, the most complex. There's constitutional recognition of non-discrimination based on health status. There's also in constitutions kind of an other status or a catch-all status that prohibits discrimination. You'll notice that there is no there's no subdivision for tuberculosis under constitutional recognition, because no constitution in the world explicitly targets or mentions tuberculosis in the context of the discrimination. Some do mention health status, and that's very good. Statutory recognition, the best thing that we're looking for actually here is a law, a tuberculosis or an infectious disease law or some kind of health law that prohibits discrimination based on infectious disease or tuberculosis. I'm giving that a full point. There could be a law that prohibits discrimination based on health status. There's disability laws. There's lots of disability laws, like in the United States, where prohibition of discrimination applies to infectious disease and tuberculosis. That's how all discrimination against people living with HIV and tuberculosis in the US is covered by laws, actually under our Americans with Disability Act, but other countries also approach it that way. There are labor laws and there's HIV laws, where you get different kinds of non-discrimination provisions that apply to tuberculosis. And then lastly, there's executive branch recognition, which would mean that there's some kind of a law or policy, maybe the National Strategic Plan, that says you cannot discriminate against people with TB or even people who have infectious disease. Overall, you can see that I'm erring on the side of kind of caution and taking a liberal approach to give countries credit for meeting these targets. And then you'll see there, I'm not going to go through these, but also for the non-discrimination target, just like the right to health, there are very specific definitions of what each of these means and how I'm awarding the points. So third is access to medicines. When you read the UN Political Declaration, you'll see that it specifically talks about intellectual property law and patent law. So there are lots of factors that contribute to whether medicines are accessible, right? But one of the most important, and the one that the UN Political Declaration focuses on, is patent law and intellectual property law. So that's why that's the focus here. So constitutional recognition for accessing medicines or health goods, products, or technologies, it gets 0.25 points. That's important, but that's whereas the other two would be the most important. For access to medicines, that's not as important as what's happening in legislation and the executive branch. But of course, if there's some kind of mention of access to medicines in the Constitution, that's good. So statutory or executive branch recognition, the number one, the best thing that gets full points is in intellectual property or patent law or regulation. There is TRIPS flexibilities more than 4 of them are explicitly established and recognized. I won't have time to talk about TRIPS flexibilities. TRIPS is a treaty under the World Trade Organization that establishes standards for intellectual property and patent law, global standards for IP and patent. And TRIPS flexibilities basically allow countries to kind of relax those standards, which promote lower priced medicines, promote generic medicines coming out of the market, allow for things like compulsory licenses, et cetera. If you're paying attention to what's happening with the COVID vaccine, you're hearing about this as well. It's the same for all new medicines that are under patent. So the third thing here is health law or regulation. Sometimes you have a national health law that says something or creates something around access to medicines. I've divided that into institutional and textual. You'll see that some health laws just use language that says there should be access to medicines. That's quite different than establishing, for example, an institution to review patents to see if they'll impact access to medicines, for example. So these are the different disaggregations or subdivisions of these sources of law. Again, you'll see there's definitions for each of these. Okay, so the assessment methodology is modeled on the UN Human Development Index. So I've essentially taken that both equation and also kind of framework. And you could, if you look that up, you'll see it looks a lot like this. So the overall index that I've created is called the Tuberculosis UN HLM Legal Rights Index. There are the 3 target indicators, as I'm calling them, or commitments to the right to health, non-discrimination, and access to medicines. And then you saw how those are graded and how those numbers are generated. And what happens then is those 3 are put together, and that creates the indicator for the TB UN HLM legal rights. And so what's the equation there? So it's, what is it exactly? So the legal rights indicator basically represents a country's overall progress in meeting the legal and human rights targets from the UNHLM in the political declaration. So basically I take the geometric mean of the 3 target indices. So the legal rights index, as you'll see, equals the geometric mean of the right to health score or index, of the non-discrimination index, and the access to medicines index. There's different reasons for using a geometric mean. It's also what the Human Development Index uses. So that's the equation. What are the results? I'm going to go through these quickly. You'll note, and I want to stress, these are preliminary results. I'm in the process of reviewing some of the laws and policies that I've already graded. And there are always, as you can imagine, new laws and policies being put forth. For example, Indonesia now has a new, I believe it's an executive branch regulation on tuberculosis. It actually may be from the parliament. I need to confirm that. But it's the point is that's brand new and it needs to be incorporated. So these are the preliminary assessment results. I'll show you the indices first for each of the targets and then the overall legal rights index. So for the right to health, you'll see here there were several countries who have got a perfect score because they have an explicit recognition of the right to health in their constitutions. And then there are 2 countries with just less than 1. India has 0.5. And by example, I had mentioned that's because the courts, the Supreme Court has recognized the right to health, but it's not in the Constitution. So there you'll see 0.5. China and Nigeria have 7.75 because they have partial constitutional recognition plus executive branch recognition. So the scores can be combined for the different sources of law. And you'll see there a map that shows the results. So for the non-discrimination index, Russia and China explicitly establish or rather prohibit discrimination based on infectious disease in law, in legislation. So they have a perfect score. You see China and Indonesia do something short of that, but still prohibit discrimination. And then the other countries do not prohibit discrimination based on infectious disease or tuberculosis explicitly. By example, I'm mentioning India, I'll mention India, Nigeria, discrimination based on HIV status is prohibited. That I do not account for, although I account for HIV legislation in other ways. I don't account for it here in the non-discrimination index. This is just to give you kind of some more of the details of the analysis. Okay, so then the access to medicines index is a little more complicated. This is the one that's probably the most preliminary. There's the most actually law and regulation to review here. You see India has a perfect score in part because they have a rather progressive patent law. And you probably know that and that's one of the things that's facilitated India's generic industry, which is the largest in the world. And then the other countries you'll see go down from 7.5 to 0.25. So this is one of the more varied results. And then, so what's the overall analysis of these 10 countries' progress in meeting the targets in the political declaration? You'll see it's kind of an interesting spread. Vietnam is at the top, Indonesia, then Russia, the Philippines, China, India, Myanmar, DRC, Nigeria, and Pakistan. And as I said, these are preliminary results, but I suspect that the final results will track somewhat close to these. And I want to thank the GDI and the GLI for having me and the union, and I look forward to any of your questions later on. Thank you very much.
Thank you so much, Brian. Super interesting presentation. So now I will introduce the last speaker for today, Dr. Ignacio Monedero, who will present on a situation analysis of the 10 high drug-resistant TB burden countries at 2 years from the UN HLM declaration, progress and setbacks in changing landscape. Thank you. Ignacio, the floor is yours.
Thank you very much. I hope you can hear me. If you cannot hear me, just let me know and I will try to sort it out. So I want to declare that I don't have any kind of conflict of interest. And during the next 20 minutes, I will try to present you the results of one interesting study we carry out in the GDI, which was trying to have a baseline, a situational analysis of the 10 high burden countries 2 years after the UN high-level meeting declaration. Now there are 3 years, right, after the declaration that we published it last year, the report, and also there is one paper already there.
And the days of unsurprised viral load.
Yes. So during this study, we try to assess what is the level of progress, but also which has been the setbacks, because we are really in a completely changing landscape, and COVID-19 pandemic have changed quite a lot of things and have created a massive disruption of TB services. Well, in fact, I've been working in tuberculosis internationally for more than 14 years, 16 years. And last year I was mainly working in COVID-19. So we were making a very basic ecological analysis, right? And the reasons for this study was trying to assess what was happening with the targets, if the countries were reaching the targets or not. And in fact, making this kind of assessment was part of the UN high-level meeting declaration by itself. We were all quite worried about COVID-19 and the potential reversion of the targets, right? So we thought that it was the perfect moment to make this exercise. So it was like a rough estimates of the different PMDTs with evaluation suitable, that could be suitable for donors, for people doing technical assistance, for the countries, right? Or even for the countries to compare within themselves. So there were 10 countries selected. We wanted to do it to more countries, but we didn't have the capacity for do so. And we selected the 10 highest burden in terms of total numbers. These total numbers were representing, as Brian has mentioned, from 70 to 80% of all drug-resistant TB cases in the world, right? These countries were Bangladesh, China, India, Indonesia, Myanmar, Nigeria, Pakistan, the Philippines, the Russian Federation, and South Africa. So they are very heterogeneous countries with multiple differences, but also with potential issues in common, because we were trying to evaluate how they were doing, because just evaluating these 10 high burden countries we were evaluating more or less, or having a baseline of understanding as a proxy for the complete world, right? 70 to 80% of all cases. Given say that, when we were starting to consider this, I said, well, probably it's not going to be that complicated, because during the last 14 years, I've been working in 6 of these countries. We have some contacts. I've been in touch with many of the drug-resistant TB managers and some of them NTP managers. But then we realized that this study, this ecological study, was not that easy as we were expecting at the very first time. So we were trying to make a cascade of the drug-resistant TB care. We will see later what is a cascade, right? We see the critical points where the patients are lost in the pathway to get cured, right? And also the original idea was making a baseline, right, of the cascade from 2018, but to do it another baseline in 2022 and see how things were going. And also just checking the landmarks, right, on the targets, if the countries were more or less on track or not, because as we mentioned, we were really afraid of COVID-19, able to truncate the targets. So we were mixing different sources. We were using the WHO TB reports from 2019 and 2020. And also we were using the specific targets, right, from the UN high-level meeting. Just to notice, these targets are described by the STOP. They are allocated by the STOP TB partnership. And we will see how during the first years of the UN high-level meeting, these targets were more or less closer to what the countries were achieving, and then they were going high, yeah, right, in order to present or to achieve a good trend, a positive trend. Also, we revised the national strategic plans. And again, as COVID-19 was there, we considered to make a survey in order to capture the information that was not captured by the National Strategic Plan or the WHO TB reports. For example, the fluoroquinolone resistant levels, the models of care, and the impact of COVID-19, and something quite relevant, the uptake of drug-resistant TB management in children, the LPA capacity, the number of Pmdt sites per country. So we developed a survey in order to get a much better understanding of what was going on. Again, some of this information was complemented by the RGLC monitoring reports and the drug-resistant TB guidelines. So something that was easy, later it was really tough because there were many documents to visit and many things to read about. So again, then the cascade of them is really a snapshot. We will see later on. But we were making this snapshot from the year of the declaration, 2018. But we consider other issues, for example, TB incidence, HIV funding. So later in the report, you will have access to all these kind of busy slides if you want to check your own country or gossip, right, about what other countries are looking like and try to make comparisons, right? As well, we make a big table, right, trying to compare the national strategic plans on key topics or how representative was drug-resistant TB or particular issues like drug-resistant TB in children on the national strategic plans. And then we make another comparison of the UN high-level meeting targets, right, for each country. So there's another table and graphs about it, and analyze and make the comparison from this drug-resistant TB survey we already mentioned. We sent the survey to 10 countries, but we only obtained the support of 8 countries. And as we mentioned, we create the surveys, initially an ecological analysis with a simple methodology, but it was really a tough and time-consuming. In fact, of course, I have a section of acknowledgement, but I want to acknowledge, because maybe among you there is people that have collaborated on these surveys, that it was like more than 350 emails. Honestly, I think there are maybe probably more than 500. But anyway, I put this figure just to be on the safe side. And again, there were multiple analyses of the 10 countries trying to mix together all this information. So it was not easy to make summary, right, of each countries. Just consider that most of them are very big countries, right? So it's complicated to figure out and try to bring together and gather all this amount of information. So what were the outcomes? The outcomes were the cascade of care with the graphs, right? And we identified 3 main patterns of the countries, right? The NSPs and the targets. We put 2018, where nearly all countries were on target, 2019, that some countries were separated, and we make some estimation for 2020. And obviously, well, the figures were quite truncated due to COVID-19. We only have partial information from the first 2 quarters of 2020, but things were not looking really good. And finally, the survey. And I'm going to use, because I cannot, we don't have time enough to talk about the 10 different countries. I'm going to put 2 examples which have similarities and differences. The first country that I'm going to more or less present it is Pakistan, right? Pakistan, by the way, I'm now involved in the RGLC monitoring mission of Pakistan, right? And by the way, doing this exercise with the GLI have helped me a lot as a technical assistant, right, for doing this kind of assessment. And also for whoever are not using cascades on technical assistant, I think it's a good exercise to try to grasp at the end, how much are you reaching to your target population or to the population we pretend to serve? For example, as you can see here in the vertical axis, we have the numbers of the estimated cases. The estimations are made on the drug-resistant TB cases who emerge on the new diagnosed cases and also on the retreatment cases. For Pakistan in 2018, there was estimated more or less 28,000 cases. So this represents 100%. All these cascades start with 100%, trying to figure out which is the population that we need to reach. But for example, due to centralization, difficulties in diagnosis, access to care, and many others, well, the laboratory confirmed rifampicin-resistant cases in 2018, it's only 40% of this total of estimated cases. So there is a massive gap there. We are not reaching to the vast majority of the cases. And from them, there is a drop of the 4% of the cases which are not enrolled, diagnosed and not enrolled. This is not something particular to Pakistan. This happens in most of the countries. So then 80% enrolled. And then going further, with a good treatment success rate, because in Pakistan treatment success is quite good, it's nearly 60 to 70%. At the end, we get only with the 7% of the initial estimation, right? So finally, for the people that we try to serve, we reach to a minimal fraction, right? And as you know, the treatment success rate has been stable for many years now. With the new regimens, things are starting to improve, right? But there are these 3 steps, and we were analyzing all the countries. Let's see, for example, South Africa. South Africa, they were having these incidents, calculated incidents, more or less 10,000 or 10,500 cases per year. So this is the estimation. And thanks to a massive political will and investment in laboratory and expansion of the gene expert and decentralization of Pmdt services, they have been able to reach even more than the incidence. So probably this reflects incidence and prevalence. Maybe there are duplicities, but you can see the efforts, right, when political will is there. From these cases, as you can see, there is a drop. This is again an important drop of cases, right? They were losing nearly 33% of the cases diagnosed, right? So it's an important drop. And then even with good cure rates, because at this time, South Africa was already using the modified Sorter regimen, they were only able to achieve a 47% cure among the 100%, among the estimated cases. Probably South Africa is the country among the 10 10 high burden countries is the country with the better performance, right? But we are not yet there, right? So just making this exercise and trying to figure out how countries are and comparing, many discussions may appear, right? So according to this, we were creating like 3 patterns of countries, right? With treatments with case detection low, which were China, India, Indonesia, and Philippines, right? Myanmar, Bangladesh, and Pakistan, right? And high, for example, the detection was really high in the Russian Federation and South Africa, probably the only 2 with not a massive gap. See below that I'm talking about the cascade, right? I'm not talking about the data presented. And regarding treatment success, it was, again, regarding not to the cohort, but to the estimation, right, of cases, it was low in, again, it was low in China, India, Indonesia, the Philippines, Russian Federation, and South Africa. But the point is, even South Africa, that it was the better one performing, was only able to reach nearly 50% of the population, right? The treatment success, right, in other sites were high because of the proportion, right, in Myanmar, in Bangladesh, in Pakistan, and Nigeria, right? But their detection rate was so low that the final impact on the cascade was really, really reduced, right? What else? Regarding the National Strategic Plan, we were able to revise only 8, and we didn't have access to 2 National Strategic Plan, the ones from Nigeria and another one from the Russian Federation. And we were evaluating the different countries according to the year of publication, how complete, and if there were mentions or a specific budget for drug-resistant TB, right? Also the indicators, if there were indicators for Pmdt in terms of monitoring the activities and impact, which most of them they didn't have. And also we see if these targets were there and how close were the national targets with the UN high-level meeting declaration targets. In fact, they were really, really different. Country targets were much lower than UN high-level meeting declaration targets. Again, most of them, the budget was increased in 2018 after those who were written after the United Nations high-level meeting. They show an increase in the budget, which are excellent news because we also wanted to see if there was any impact, right, in drug-resistant TB after the declaration. Right? And again, in those countries, we were checking for clear policies to reduce the gaps in diagnosis, in enrollment, and in treatment success. Right? Again, not in all. Right? So it was really an effort, but it was a valuable process. Regarding the targets, we were looking at the precise number per country, right? Because the targets were in total numbers established by the Stop TB Partnership in 2018, and then they were modified in 2019. These targets were related to drug-resistant case diagnosis and drug-resistant case enrollment. In fact, I really miss here the treatment success, right? There was no target on treatment success. Probably in future policies, it's something to consider about, but it was just on diagnosis and enrollment, and this is what we were measuring and looking. So the time frame from these targets were established, as I mentioned, 2019, closer, and then escalating. And important to say that the targets were becoming more ambitious from 2019, and then after in 2021. But as we all know, the pandemic have changed quite a lot the panorama and the landscape. This is, sorry, because of this busy slide. As you will see, the whole point of this presentation is for you to grasp the interest and go and take the paper and check the data from your country and from other countries. Again, the targets on notification and enrollment were comprised by just a few number of countries, probably 2 or 3, but I'm not going to explain the 10 countries because unfortunately we don't have much time. But I'm going to visit those 2 countries that we were using as example. Pakistan, for example, in 2018, this was the target in 2019, that it was relatively close to the diagnosed So the target was put more or less in 5,000 patients to be diagnosed. They were diagnosed nearly 400 and then enrolled into treatment nearly 3,000. But for the next year, as you can see, the diagnosis capacity and the enrollment capacity in Pakistan was more or less flat, similar numbers than the previous year, but the target was going up. So there was a massive gap between the target and in both in diagnosis and also in treatment enrollment. This is the example of South Africa. In South Africa, the target was more or less for the 2 years put on 10,000 cases. And as you can see, it was achieved in diagnosis, right? It was wide beyond in 2019, but also in 2019. And South Africa was really close as well to the enrollment target. But given say that, if we only look at the crude rate and the crude data, we miss some information because losing nearly 3,000 cases and not put into treatment, this is obviously not a good result. So again, we were trying to figure out the indicators and see the indicators from multiple angles. Even if they were close to the target, there was room for improvement, right? Trying not to lose as much cases as were diagnosed, right? Because these two lines, they should be together. All patients diagnosed should be put on treatment and hopefully also cured, right? Regarding the survey, we obtained 8 responses to the survey, all countries except China and the Russian Federation. And going into the precise questions, because I'm going to split the different questions. There were 22 questions, but I'm going to split in big blocks, right? And just to go and try to show you the outcomes regarding the UN high-level meeting itself. All those countries, right, seems to have improved their budgets and plans, right, before 2018. Most of them couldn't compromise much money or much funding or allocated yet because some of these national strategic plans were done before 2018. But certainly in all the countries, they consider that also the declaration itself and also the targets was helping to assure fundings, to assure human resources, and was guiding on future actions and plans, right? So again, countries, most of them, they were revisiting their guidelines. And so even if things were not perfect, there is ongoing progress, right? And some, well, I will continue because to me, the key information captured by the survey comes in these four issues. For example, fluoroquinolone resistance among drug-resistant TB cases or rifampicin-resistant TB cases, it was much more higher than expected. In fact, there was one country with 37% fluoroquinolone resistance, right, among the rifampicin resistance. So I was really worried when I saw this data. It's not the only country. There are other countries with 20, 25, there are high levels. The point is that if these countries do not have access to fluoroquinolone resistant very quickly, and they are allocated into the current short treatment regimen, right, just to please WHO or just because it's already there, they can end up creating a problem with beta-alanine resistance and increasing the patterns of resistance, right? So it's an issue really to check out countries with high levels of resistance and low LPA capacity. I really hope that the expert XDR really is up to our expectancies. Again, the main reasons for loss to follow-up among drug-resistant TB patients, it was socioeconomic, but also a key issue, right, that they mentioned that distances were really a challenge for most of the cases. And in fact, we get some figures about the number of Pmdt sites and the population. We divided just to see, just to have a rough estimate on how is decentralized. For example, there was one country where there is one Pmdt site for every nearly 20 million people, right? So at the end, this is like like looking for a needle on a high stack, right? So there is a strong need for social protection, and there is a strong need to decentralize Pmdt services with quality, right? And probably we are not going to reach the people if sites are really far away, or they are serving a massive amount of people. Again, we were asking about the barriers for Pmdt implementation, and what we found, right, is that most of these high burden countries, the level of political will is really low. Most of them are donor-driven policies, and you know, donor-driven, donors want results quite in a short period of time, demonstrate that their money they invest was making a difference. Okay, that this is perfectly fine, and we have to be really thankful to Global Fund and many other donors. But the point is that if the government is not investing, we will have problems with human resources, stable contracts, and long-term vision, right, and long-term solutions, especially related to health system strengthening. It was really an issue there, right? And the fourth striking result was children meaning under 15. In most countries, there was basically no data on what is going on with children. Of course, there are many children treated, but the data was not disaggregated or not captured. In fact, among these 10 high burden countries, we could only notify 1,051 children, and they were mostly from South Africa, the Philippines, and I'm sorry, I forget now another country. But this 1,000 children, it's really a minimal fraction, and this was for 2 years, right? And this represents less than 1% of the UN high-level meeting target for children they were expecting to get between 2018 and 2022. 115,000 children. So it's, sorry to say, but it's a ridiculous number, right? Something's going really wrong with drug-resistant TB in children, maybe because countries are expecting to have diagnosed bacteriologically, that we definitely, as you know, children are paucibacillary, and we are not going to get it. They do not behave like a small TB patient. They behave differently. You need special samples from urine, from feces, consider the epidemiological fact and the clinical facts, right? And do not expect that the vast majority are going to have been bacteriological positive. So I think there is really a gap there with children, and we already knew that, but this is another confirmation that they are for sure the most neglected population, right? Okay, and the last important information from the survey, that is COVID-19, the impact. The impact was really high, and we were expecting that, but there was a massive diversion of human resources. As I mentioned, I've been working in TB for 14 years, and I spent nearly last year working right in COVID-19 in my own country, in outbreaks in nursing homes. So there have been a massive diversion of human resources, funds, facilities, and they were people from TB going into COVID-19. So the systems have been severely disrupted. Again, it was not only about the human resources, lockdown and difficulties in mobility. So there were big barriers for patients going and getting health-seeking behavior. Most countries are saying that they were delivering the drugs, but for sure, the monitoring have been much reduced. Probably there were side effects. Patients were all alone or using telemedicine, right? And again, there were important delays in the turnaround time for LPAs, DST, notification of new cases went completely down, and it's been similarly to all countries. So COVID-19 has compromised the three big steps right on the cascade. It has decreased the case finding, it has decreased the treatment enrollment, and because of less monitoring and support, probably there has been a delayed evaluation. We are expecting an increase, loss to follow up, right? And there was probably no DOT at all, right? And probably there was an additional danger into this, that is GPs and private sector telemedicine, as most of the public services or TV services have gone to COVID-19, or the laboratories have been hijacked into COVID. There have been an increase of telemedicine and self-use of fluoroquinolone, which is potentially increasing the resistant pattern. During the recent RGLC monitoring mission to Pakistan, we have seen that the levels of fluoroquinolone are going high, and these are really, really bad news. So overall, the UN high-level targets and trend are going to be truncated. We mentioned this 1 year ago, but now we can confirm that they are completely truncated. Right? Okay, I cannot go to the next slide. I don't know what's going on now. Okay, so I'm about to finish my presentation, and I want to acknowledge the massive amount of people that has been collaborating, right? Many people from the NTPs, many people from WHO staff from the 10 countries. I'm sorry I cannot name them all, but this is not a one-man issue. It's been really a teamwork with many, probably 40, 50 people already collaborating in this. So thank you very much all. So I want to appreciate all the work from the GDI group members and WHO staff in Geneva for supporting and making available this study, all the feedback. And finally, I want to give a special thanks to Medea, Jeja, and FaceAware, Sarabjit, and Fuad Misayev for all the collaboration and for keep pushing for this study to be made. So the highlights of this study is that despite the meetings and the targets from the UN high-level meeting, the cascade of care shows that the patient care is very reduced. Right? We are not reaching to the population that is in need. We are not yet there. We are very far away from what we should be doing or pursuing. Again, a big worry, and especially for the people that we work or we've been working in drug-resistant fluoroquinolones, that is the cornerstone of the current regimens. It's really jeopardizing and can limit the access and the limited access, of the drug susceptibility tests can hamper the scale up of shorter regimens. And this is really a tragedy if we want to decentralize. Finally, the worldwide programmatic management of drug-resistant TB in children is so scarce, it's really minimal. As we mentioned, the coronavirus pandemic has jeopardized the drug-resistant TB achievement, right? So probably the key message from this is there's a strong need for major investment and to keeping the spirit of the UN high-level meeting declaration. So even if I'm a clinical person, and I also work as public health and a PH, right? The big picture of the big differences on the policy agenda. So whoever is here, please get convinced that your job is fundamental. We are reaching a minimal and the big fighters on the policy arena, and keeping alive tuberculosis, well, not tuberculosis, but fighting against tuberculosis is more important than ever. So finally, I'm going to put a picture. This is Andre. Andre is children from the Philippines, right? As you know, as Spanish people, we are hot blood people, right? And I was delivering a training during the decentralization process for nurses. And one nurse came and mentioned about this case, and it was a drug-resistant TB child that there were plenty of reluctances to put him on treatment. And we were really pushing for this case to go that. And finally, these children was starting with a short treatment and was finally cured. Right? For me, it was another case discussed, another clinical case discussed. But the point is that despite I'm still young, I'm 45, I was going for a surgery. And as many of you, for sure, I'm a completely workaholic, and I was revising my emails before the surgery, which is something quite stupid. But I received this picture, right, from the nurse from the Philippines. And I said, well, maybe I'm not moving the agenda, but I contribute to save and trade. And this is probably what we have to do, right? We go from a micro triumph to another micro triumph. And despite my presentation is all about bars and figures, just mention that, for example, for me as a father, my children are my universe. So just hearing Andre, okay, I was making a big universe. And in fact, I have this picture here on the back of in my office, right? I don't turn around the laptop because I don't want the connection to go out. But I have this picture just to remember who are the people that we are serving. What is the purpose of what I'm doing? Right? And also when my children say, oh, that's not working too much. Yes, but okay, we are achieving great things. So please do not forget then that beyond these numbers and this reduced number of children and these gaps, there are people like Andre that we can really make a difference. And just to finish with this, where to find the paper. I think it's not very elegant, right? Recommending your own paper, not elegant at all. But if you want to check your country, check what other countries are doing, or you are just working in technical assistant, or you have interest in drug-resistant TB, there is a shorter version here, right? And it was published a couple of months ago in the International Union, in the International Journal of Infectious Diseases, completely free, right? You can just go into this link, or just put in Google UN high-level meeting, high drug-resistant TB article, whatever, and you get it there. And also the report, which is not that big, it's nearly 60 pages. If you have a special interest, go to this. And with this, I will finish and give the voice to the presenters and the chairman. Thank you very much. It was really a pleasure. And please keep pushing the agenda, because despite our paper and our job give us really bad news, I think we need to keep pushing for all these Andres that they are already there. So if it's something in your hands that you can do, please go for it, and let's put TB on the international agenda again. Thank you very much.
Thank you so much, Ignacio. Amazing presentation, and thank you for sharing this touching experience. So now we have concluded the presentation, and we will go into a break. Before that, I will give the floor to Caroline to give some info. Thank you.
Yeah, hi participants. So we will break for 5 minutes, and I would recommend that you do not log off from the Zoom meeting, as we're going to go into breakout right after. I will display a countdown slides for your reference, so you know when to join back. Thank you. Welcome back. The course will now resume. So for the next 30 minutes, you will be working in groups in breakout rooms. There are 2 different rooms, and you will actually have the opportunity to choose whichever you want. Please note though that a pop-up will appear on your screen, and you will need then to click on whichever room you want to go. And you need to accept the invitation to join the breakout. We encourage participants to turn on their webcam and to be as participative as possible during both breakout group. And you will see 1 minute prior the end of the breakout activity on the top left corner of your screen, a little clock that will tell you that you have 1 minute left. And then you will be brought back directly to the plenary. You will not have to do anything. So prior opening the breakout rooms, I will hand it over to Dr. Tagliani, who's going to explain you a little bit more about those 2 breakouts.
Thank you, Caroline. So you will have the opportunity to choose between 2 breakout sessions. One will be specifically focused on the GLI work and focus on diagnostics. The other one will be more relevant to the GDI work. So we'll have 30 minutes to discuss 2 specific topics. And at the end, we'll have a reporting session where the key points will be highlighted. As Caroline said, please don't be shy. We really need to interact, and we are eager to know your opinion on the different topics. And having said that, I will leave the control to the union so that you can select the breakout session that you want to join. Thank you.
Challenges and opportunities for the uptake and implementation of the latest WHO TB diagnostic guidelines. And the first question that was discussed is what are the main challenges countries are facing in the implementation of these new WHO recommendations and what solutions people could think of. Well, some challenges that were mentioned is that there is still a very slow transition from expert MTB-RIF to expert ultra. It's not going fast enough. Some of the referral systems are maybe not, they are not strong enough, and maybe they're not, availability is limited in some places. There is a need for a more coordinated approach for TB technology implementation. And this should be supported by WHO and involving all stakeholders. And it was also suggested that perhaps the TrueNut could be used at sites where gene experts cannot be used, and this is maybe not not rolled out a lot yet, and that could be one of the solutions to increase the access to the methods. And I think one of the barriers is certainly in Eastern Europe was mentioned that some of the guidelines are only the guidelines are in English, and it would help a lot if they are translated to other languages, and that's certainly only not for Russian but also for other languages, of course. One of the opportunities that was mentioned that countries can exploit when implementing the new WHO recommendations is they could explore local opportunities to use the COVID-19 expansion of testing and communication capacity for TB testing and reporting. Maybe before we move on to the next topic, I would like to ask Petra or others of the breakout session if you have any additions to this.
Thanks, Christine. I think you cover well the topic of our discussion. I will encourage you to report on topic 2 so that we can also hear from GDI. Thank you.
Okay, then I move on to the next topic. That was about the new definition of XDR and are high burden countries ready to diagnose it? And then we had 3 sub-questions. And the first question was what might be the bottlenecks to scale up rapid molecular tests to detect fluoroquinolone resistance, and how can these be tackled? And it was indicated that certainly in some countries there are still limited resources, and that the consequence is that therefore there is also limited access, for instance, to line probe assay or drug susceptibility testing. Also, of course, there are no good rapid diagnostic tests for the fluoroquinolone resistance and some of the other new drugs. And therefore, there's really need for more DNA sequence data so that we gather on more data and we get more insights in mutations that are conferring drug resistance to these drugs, which are currently still unknown. Barriers that were mentioned in the scale-up for laboratory capacity to perform drug susceptibility testing is that, it was certainly indicated that there was in certain countries no capacity to do DST to these drugs, to these new drugs at all. So that's a big barrier. And of course, we need to therefore increase the capacity to test by training, etc. Also, another challenge is regarding the standards. It's not always clear what, for instance, low levels of resistance indicates. What does it mean? Then there we did have another question about the reporting, but unfortunately time was too limited to really discuss that. So maybe anyone, Petra, do you have any additions?
No additions from my side. It's only that the point on need for DNA sequencing data is one that mainly belongs to the bedaquiline and the linezolid, because there's still a lot to discover at that side. And I think for fluoroquinolone, we have a lot of information already, but that's something that yeah, that's good to look at. But it's really covered well. Unless Elisa has some other things to say.
No, I think you well cover everything that was discussed. We would have needed more time to finish, but the time is what it is. So without further ado, I will give the floor to Ignacio or Sarabjit. I don't know who is going to report about the GDI breakout session.
Well, it's me again. This is Matthew. I will share my screen. Right? Okay, can you see it properly? Yes.
Yes.
Okay.
Yeah.
Okay, so I'm going to the two different topics that we were mentioned right while we were here. The two questions were first one on the topic challenges and potential solutions or steps to meet the UN high-level meeting targets. The first question was, what do you think that the current UN high-level meeting representative targets are very ambitious? And most of the people mentioned that they were ambitious and achievable, but on the light and the circumstances with COVID-19, it's going to be really difficult to achieve them. Other people, they say that they are mainly okay, and there were also some participants that mentioned that they were not enough ambitious, right? But more or less that there were a consensus that they are hard, but they are achievable, or maybe that they should be achieved, right? Question number two is, in your opinion, which ones are the key challenges and gaps for the current difficulties for the uptake of the targets? Again, this is a discussion that we could have for ages or for days, right? And so we didn't have enough time for cover this, but most of the people say that different countries that have completely different distribution of problems. But again, people from certain countries that were mentioned, that diagnosis on the cascade was the main limitation, as well as social stigma. But there was also a consensus that political changes and political situation were really a challenge. I guess that this is a challenge referred to health system strengthening, right? And to create the necessary human resource system in order to achieve the targets, right? Again, some of the people, they mentioned that they were already in some countries who were burdened with other diseases that they cannot spend enough time or resources with tuberculosis. The third question was, based in this challenge, which are feasible or high impact steps to catch up with the targets, right? Again, they mentioned that try to increase the case detection rate after COVID-19 should be a priority. But again, probably using the similar infrastructure from COVID-19 or just seeing how people have reacted against the pandemic, it can be, in a way, transfer this knowledge or this attention into tuberculosis. Again, many consider that it's really need to get involved the social society, including religious leader, and finally to strengthen the system for enrollment of all cases that they were already diagnosed. Okay, regarding the topic number two, the question was leveraging digital tools to meet the targets, the UN high-level meeting targets. The first question was, which digital tools present the most exciting solutions to NTB, and how do we efficiently integrate them into the existing health systems, right? Ensuring good access and also affordability. Again, they were mentioning, most of the participants, that mobile phones have multiple applications, especially continuous education. Then revamping, I'm really sorry, recording and reporting notification. And also the use of mobile phone and other application for tracking other ends and treatment other end tools like texting or phone calls or application, even video DOT. Some other participants, and also it was quite interesting, mentioned that despite all these applications are there and they cannot replace the human touch and the human work. So it was really a call to go back to the principles, right? Medical acts usually need them to be real interaction face to face, right? Other people mentioned that plenty of tools have been developed for COVID-19, right? That it could be transferring to tuberculosis, for example, for tracking contact or contact investigation. But again, all the participants mentioned the importance of electronic databases and the capacity to directly create reports and having real-time information. Plus, for example, transport tracking tools, right, widely available for many other goods, but not in health and not in tuberculosis. There could be things that can improve. The second question was, according to the immense promise of digital health technology, also comes with an equally immense responsibility to protect the rights to autonomy, privacy, confidentiality, and non-discrimination of people affected by TB. So how do we fully leverage exciting new technologies while fully protecting the most vulnerable who need at the same time most? There was a consensus that this was a really hard to respond question, right? Some participants openly mentioned that they need to think about it, right? They didn't know how to figure out, but I think there was a common agreement that there is a risk of vulnerability and that information can be crashed and vulnerable quite easily. There have been recent experiences with Facebook providing intimacy or private information to people that can do whatever they want with that. Right? So again, a hard to respond question. Okay, with this, I finish this. Thank you very much.
Thank you, Ignacio. So now can you mute yourself? Okay. Now we go to the very last session. We only have time for one question, unfortunately. So just a second. There was one question for Brian. Hope Brian is still connected. So the question is, can the system as you presented be easily used for any country to calculate this indicator? I think you replied by chat, but can you briefly explain how can other countries use the system?
Yeah, sure. So the short answer is yes. Once the report, there's going to be a brief, like a short version of it that'll be published by the GDI, and then I'll be trying to publish the full article in a journal. So when one or either of those come out, the methodology and all the the equation and the all the charts that I showed in the presentation, that will be out there in the public. And if anyone is interested before then to take a look, please get in touch with me. But yeah, the short answer is yes. I mean, first of all, it's not country specific because I'm looking at 10 countries, right? So any country or anyone could apply the same framework to any country. But I think, so yes, we could look at not just the 10 high DRTB burden countries. We could, and I think the most logical thing would be to look at just high TB burden countries, right? So I'm focusing on DRTB as a member of the GDI, but with funding and time, we can easily do the same thing, and it would be quicker, I think, to do it now that we've done it once for other high burden TB countries. But the last thing I'll say is that it could easily also be applied to HIV or COVID or NCDs. So because the framework is neutral and agnostic in terms of the disease. And then of course I'm applying it in the context of TB. So the short answer is yes, it could definitely be applied more broadly. I hope that could happen. I'd love to work with anyone interested in doing that. Thank you.
Thank you, Brian. And as I was looking at the chat, I think there is a comment from Dinesh about the digital tool that can be the digitalization of community-based TB scorecard. So we still have a few more minutes. Dinesh, if you want, you can expand your thought.
Yeah, thank you once again. I have talked in our breakout rooms, and what I was trying to suggest that to know the satisfaction of the community, that means the people, those who are receiving the care, their satisfaction can be assessed by various ways. One, by the health system, and second, by people themselves can give scoring to various kind of treatment services. And that can be digitalized so that the health system providing the services can look at that to what an extent people are satisfied for, and if yes, to what kind of services they are satisfied most, and what kind of services they are satisfied less, like treatment, diagnostic, sputum sample collection, initiating the treatment, getting the drugs, or things like that. So that was my idea, because we have developed TB. Most of the countries also have developed, but we're trying to develop and adapt the community-based TB scorecard to know the satisfaction level of the community, but also as in a very participatory action research mode, which can also suggest some solutions to the very healthcare system at the grassroots level. So it's a kind of a monitoring as well as kind of an intervention itself. So that was the whole idea, whether we can do things like that to make more out of it. Thank you very much.
Thank you, Dinesh, and indeed that is an aspect that is always often overlooked at. So I would ask the moderator if maybe I've missed some question, or if you have any burning question, you can just take the floor and ask directly to the speaker. Okay, the moderator says that there are no further questions, and I think we are at this point at the end of our workshop. I really wish to thank once again all the speakers and the participants that greatly contributed during our breakout session. I really hope that you enjoyed this workshop as much as I did. And I don't know if Sarabjit, you had some problems with the connection. Sarabjit, would you like to close the webinar?
Right. Thanks, Elisa, and thank you everyone for participating, and thanks to the union for organizing this workshop. I think it's been very successful. We had a lot of participants, and I just hope that the discussions from this workshop and the evidence presented will be taken forward by the countries to help improve the diagnostic and treatment services towards our goal for eliminating TB. Thank you all, and thanks to all the speakers and my co-chair, Elisa.
Thank you, Sarabjit. And with this, I'll give the floor to Caroline to close the workshop.
Well, thank you, everyone, for attending today's workshop. So once this Zoom meeting closes, you will see a survey appear in your browser. We would appreciate if you could complete it and provide your feedback. it's important to complete the survey right away because the link then will not be available after a certain time. You will receive a follow-up email in the next few days with a link to view the recording of today's event. And don't forget that discussion like today centered around the latest research in science take place every year at the Union World Conference on Lung Health. So join us for this year's virtual conference next week on the 19th to the 22nd of October. And on behalf of the union and our presenters, thank you for joining us today and have a good rest of the day. Thank you very much.